What is your current protocol for extirpation? So let's say you made a diagnosis of irreversible pulpitis. Your patient is in raging pain and you have to squeeze in this pain-relieving treatment, a extirpation probably of a lower molar or something, in 5 minutes. What are you going to do? Well, some of you will listen to this and it will be validation and revision. And you'll be thinking, wow, I've been doing it right all this time, even though I thought maybe I was taking shortcuts, but actually I've been doing it right all this time. And others will be like, whoa, this is so much easier compared to what I'm doing at the moment, because the big hint I can give you is that you don't even need a K-file for your molar extirpations anymore after today, because I've got Dr. Sanj Bhanderi, specialist endodontist, to talk us through what is the right way, the proper way to do an extirpation of your patient who is in pain. And there are just so many gems, from pain relief, diagnosis, isolation, and what I love about Sanj in this episode is that he's not dogmatic. Yes, he's a specialist endodontist, and it's so easy for him or anyone to say, you must always use rubber dam. But he actually does discuss a scenario that, okay, if for whatever reason you had to do it without rubber dam, how can you optimize the isolation? How can you reduce the saliva getting inside the tooth? So I really appreciated that about this episode, and hope you will as well. It's very much in tune with the real world. And lastly, we do cover his step-by-step, what is the right and proper way to do an extirpation without wasting time and without actually making things worse for future treatment. So I hope you enjoy this episode, and I'll catch you in the outro. Dr. Sanj Bhanderi, welcome to the Protrusive Dental Podcast. How are you, my friend?
I'm very well, thank you, Jazz. Thanks for the invitation. Excited. Not done one of these before.
Oh, well, I'm amazed it's your first time, and you're a real hero of mine, Sanj, because I don't know if you remember, 10 years ago, I met you at the British Endodontic Society. Can you believe it? Is that long ago?
God, 10 years. You know what? Everything's a blur nowadays at my age. Could have been yesterday and it will be still seem the same. But no, thank you. It's lovely to be here. Thank you, Jess.
Thank you so much. And I remember your lecture even then. I remember some of your lectures at the BDA. And probably because our paths haven't collided, I haven't seen you. I knew you're very active with your teaching, but our paths haven't collided since then that much. But it's great to have you on to talk about a very important topic, which is how to get a patient out of pain in terms of your diagnosis of irreversible pulpitis. And we're going to talk about what is the optimum and best Sanj-approved way of dealing with that you wish your referring dentist would do. And the other one we'll talk about is post-op pain. But before we dive into the nitty-gritty details, just please tell us listening, it's an international audience, in terms of where is it that you work, what got you into endo, a bit of your background.
Sure. Yes, I've been in this game in endo anyway dentistry, I suppose. If we go all the way back, it's going to be our 30th anniversary next year, so which is a bit frightening. So now I'm qualified in London. I'm actually a Londoner, but I now live in Manchester, and I've sort of wormed my way up north to the northwest, mainly by accident really, and just hospital jobs initially came up. Then I did my postgrad training up here. I mean, back in those days, 1995, there were only 3 postgraduate endodontic programs outside the hospital training pathway, and it was either London or Manchester, and I happened to be at the right place at the right time in Manchester. I got onto the Masters quite young, actually, quite early. I think I was the first one in our batch in our year at Guy's, and I wasn't a high-flying student at all. I managed to first one to get an MSc, and then I stayed in Manchester at that time in the mid-90s. I don't know if you're too young to remember, Jazz, but it was quite a good university town city. And it was. I think I had a better student life as a postgrad than I did in London. But no, things were changing in Manchester. The dental school was good. I was teaching. There were not many endodontists. One of the reasons I stayed up north, actually, because I knew the job prospects would be better. This is before endo became really popular, and I could see it. In fact, it's by accident I fell into endo. It was going to be either implants. At that time, there was an implant MSc and there was an endo MSc. Because that was one of the only implant MScs in the country, I was too young. I would never have got on. The people that got onto that were experienced practitioners, and I really had no chance. But that's where I was going to go. Ironically, the opposite way, and I ended up doing endo, and it's sort of taken off from there. And I just got into endo, and I stayed in Manchester, got job offers, and I've pretty much been full-time endo day one from finishing the masters, so since '97.
So how many days are you clinical at the moment in terms of doing your endodontics referral practice?
Yeah, so I'm pretty much now full time, as in I was 4 days. I'm down to 3 days now, and I've got an associate, Rob Jacobs, who covers me. So I'm down to 3.5 days and teaching now, just doing private courses up and down between London and Manchester with a couple of friends. So that keeps me out of the practice. But pretty much I've always been a hands-on clinician.
So you're very wet-fingered, very clinical. You got a great name in the UK as the person for endo. So again, it's a privilege to have you on. The reason I have you on is because Extirpations, I speak speak to different colleagues and we all kind of do it differently. So I want to find out, what is it that you recommend? And I remember asking an endodontist some years ago what they recommended. And I got an interesting answer from the endodontist. He said that, you know what, as an endodontist, I rarely get to see the emergency extirpation cases anymore, because usually by the time they've come see me, there's a sinus tract, there's a perioendo lesion, and they're really complicated. So firstly, I'm just being nosy. How much emergency extirpations do you get? How many of those phone calls do you get? How many do you actually treat in that regard?
In terms of the practice, you're absolutely right. Being an endodontist, we by the time they get to us, they're either non-vital, previously root filled, or the dentist has had a go at doing it. We get a lot of phone calls, and mainly from dentists. What do I do? How do I numb the tooth up and this sort of thing? We'll talk about that shortly. But in that way, I'm kind of slightly lucky, although I know how to deal with it. And we have to, back in the training, working in dental school, you're in the emergency, the dental casualty, whatever they call it nowadays. So you had to deal with that. You had to learn pretty quickly. One of the reasons I went into endo is just, okay, it's not just about the white lines at the end of the endodontic treatment. Right at the beginning, getting patients out of pain, immediately out of pain, just until they relax and you get them back into the proper endo. That is really important. And in that way, I'm kind of shielded being in specialist practice, because it's my general dental colleagues there at the coalface, and they've got to deal with that stuff on a Friday afternoon just before they close. Patient rocks in, and they haven't slept for a week, and they're anxious and they're nervous, they've never been to a dentist sometimes, and you've got all that to deal with, and you've got to get them out of pain. And you can't fob them off with antibiotics. It's just not appropriate nowadays. Medical legally, it's not. You could get into hot water if something happens. So you've got to be able to get in there and deal with it efficiently, as painlessly as possible, and that's the challenge, because the tooth is extremely inflamed. And just stabilise everything so you can get them back in when you've got plenty of time, or get someone else to do it, whatever the protocols are. But that is important, yeah.
Okay. Well, before we go in for the kill and talk about the exact protocol that you would recommend to alleviate someone out of pain, let's talk a little bit for the younger audience listening, maybe students who are listening right now, just coming up with a diagnosis of when it is appropriate to give antibiotics, because perhaps it's necrotic infected and really it might already be root filled or whatever, and then what kind of history and clinical findings are leading you towards a diagnosis of irreversible pulpitis that needs that intervention that wouldn't settle with antibiotics. Can you just give a distinction between the two different types of patients?
Okay, so you've got two different situations. You've got the root filled and non-root filled tooth. I won't talk about the root filled tooth yet, because that's a slightly different scenario. But on a tooth that's either potentially vital or semi-vital or partially necrotic or completely necrotic. Okay, so you start from the disease process obviously starts at the top of the pulp, typically caries, tooth fractures. Bugs have got to get into that pulp. Now, sometimes the patients will have very low-grade symptoms and a niggle, a dull ache, maybe a bit of thermosensitivity, and they kind of put up with it. And sometimes those pulps will die. But it's the ones that don't die or die painfully, and they go through an acute phase, what we describe as irreversible pulpitis. They're the ones that are the challenge, because the top of the pulp, the pulp that's the most inflamed closest to the insult, could be caries or a fracture. That bit of the pulp will be difficult to anaesthetize. So when you give a blocker, typically for a lower tooth, you'll give a block anesthesia, you'll give it an infiltration. The anesthesia will not penetrate up the ID nerve. It won't get into the pulp. It'll get into the pulp, apically, maybe radicular area, but it won't get to that point which is the closest to the insult, the most inflamed. That's the challenge. Getting from where I describe it to the patients, I show them the x-ray. This is your tooth. That's the top. You've got aura filling there. We need to go from the top, the occlusal surface, down to that pulp chamber bit. We're going to go down to there. Now, a lot of it's patient management. It's preparation, okay? Because we'll go through the anaesthetic protocol, which hopefully will work, but sometimes it's just not going to work. But you need to know that, and you know that from the patient's symptomology. When they walk in, you just know that as a hot pulp, there's a chance that you're not going to be able to anaesthetize them. It doesn't matter what you hit them with. There are a few things we'll talk about how to prep that. If they haven't walked in off the street, if you know there's a pulpitis coming in, there's a few things you can ask them to do before they come in, just to help the anaesthesia process. And then when they get them in the chair, it is management. It's a lot of good anaesthesia, multiple techniques, different agents, and then going in carefully and managing the patient, being empathetic, but up to a point. If they can't tolerate it or their anxiety levels too much, you sometimes have to do it in stages. Sometimes you've got to go for it, and sometimes you've got to be cruel to be kind, but in the appropriate patient. Mm-hmm. You can't just dive in and you'll lose a patient, and it's just not nice. You've got to imagine yourself in that position. But equally, you want to get them out of pain. So it's a balance. It's a real fine balance.
Yeah.
Based on
Just the other day, I saw a patient in acute pain, and after getting somewhat good anesthesia, objective, I tried with endofrost -50 degrees beforehand, managed to elicit a necrotic response compared to the others actually. But he had recent symptoms of irreversible pulpitis, so it was probably mostly necrotic, but there's still some element of vitality to it based on his symptoms he was presenting with. And so when I did manage to reach the pulp chamber of this lower molar, placed a file just into the distal. Now this wasn't bleeding, so it confirmed my diagnosis of necrotic. But I saw the white pulpal tissue. So as soon as I put my K file into the distal, he pretty much jumped out of the chair. So I gave the intrapulpal, and that just settled him. So it kind of culminates. And like you said, I had to be cruel to be kind for that patient. Now, what could I have done had I known? I didn't know he was coming in, but what kind of anesthetic supplement or advice could I have given on the phone, as you alluded to help achieve better success rate of anesthesia?
Yeah, it's about reducing the inflammatory status of that pulp as best you can. And systemically, there's plenty of evidence to say that loading them up with anti-inflammatories, non-steroidal, so 400 to 600 ibuprofen, with or without paracetamol. If they can't tolerate anti-inflammatories, asthma or stomach issues, tramadol, something like that, or codeine, paracetamol, not as good as an anti-inflammatory, but it's better than nothing. That will just physiologically reduce the inflammatory status. It doesn't guarantee that tiny bit of the pulp that's inflamed will completely anesthetize, but it'll definitely, there's plenty of evidence saying it will help the anesthetic process. In terms of the actual local anesthesia, for the lower teeth, always are notoriously the worst teeth, molar teeth, first, second molars. Those teeth are really difficult to numb, and it's because they've got accessory nerve supply as well often. And for me, the baseline technique is doing an ID block. I don't mess about with intra-PDLs and this sort of thing, and you just need to knock that nerve out, not as much as you can, supplemented with buccal infiltrations of an agent that absorbs well, and for me it's articaine. So for my ID block, I would give lignocaine as a start. This is in acute emergencies. I don't use lignocaine often actually. Yep. I'll tend to fall back on mepivacaine. We can talk about that later on why I prefer mepivacaine for routine endo, but for hot teeth you need profound anesthesia. You don't need longevity, but lignocaine works pretty well as an ID. I'm not a fan of giving ID blocks with articaine, but I know the evidence suggests it is very good, and it's controversial about the risk of paresthesia. And it may not be anything to do with the agent. It's probably to do with the fact there's trauma from the needle. But I'd rather not, if there's an alternative in it which works just as well. So ID, lignocaine, wait for that to work, completely work. So we're talking your lip is completely numb, the lingual mucosa are completely numb. Not even the patient can't feel a thing. Then articaine, buccal infiltrations. It tends to absorb better through the buccal plate. It's pretty thick, especially in the 6 and 7 area. And then I might give PDLs as well, or lingual under pressure. I've got an intraperidontal device called the wand. There are a few other devices now available which do the same sort of thing. They're basically under high pressure with a short needle. They can deliver the anaesthetic through the PDL. And the theory behind that is a PDL is almost as good as an intraosseous. Intraosseous is the other mechanism. You can drill a hole into the bone through these self-drilling devices, which has a pretty good effect. I've never got used to those devices, but some people swear by them. But you need to get that profound anaesthesia in there, and you just got to wait. Just make sure that the anaesthetics work. Don't just dive in, and then you're on to patient management.
Well, with the busy lives of general dental practitioners, juggling act, getting these patients in, making the diagnosis can take 15, 20 minutes. Sometimes you take a radiograph, then give them the block, let's say, articaine infiltration, get them sit outside while you see a few more patients. I'll see you in my lunch breaks, Mrs. Smith, or whatever. Then the lunch break comes, your nurses rolling her eyes, they swap nurses, and so it's all happening in busy practice. Now, let's say we made our diagnosis of irreversible pulpitis and we know we need to extirpate. We have given sufficient anesthesia and the patient loaded up with ibuprofen and all the stars aligned. When we're dealing with such teeth, they usually have large MOD amalgams or something like that, right? So my first question in terms of making it very tangible for general general dentists is, in an ideal world, we'd love to remove the entire restoration, remove any caries, access for cracks, but in after 20 minutes, we need to get in, go for the kill. Is that okay? Can you forgive us?
No, it is. At the end of it, this is about patient. This is about getting the patient out of pain. Okay, and you just need to get in there. I used to call it ninja endo. Get in there, get the job done, get out without the patient realizing it. That's my principle in endo, whether it's emergency or endo. You want to be
stealthy.
Stealth. Okay. And the first priority is get into the pulp. you're releasing by going into the pulp, you automatically release pressure. There's pressure buildup. That's the number one property of inflammation, isn't it? Then you need to basically you're applying a sedative material to relieve the inflammation. The most common and popular products are steroid based.
Before we talk about medicaments and stuff, before we talk about the medicaments, I just love to ask some real world questions. Like, let's say you go in, you open up the pulp chamber. Do you think is desirable for the practitioner who's going to refer to you in the future? Should we be also removing the roof of the pulp chamber as much as possible? So let's say that lower molar I saw the other day had 4 canals, mesiobuccal, mesiolingual, 2 distals, so 4 canals. And I opened it all up as much as I could to visualize those 4 canals. And it was mostly restorative material I was removing at this point. Now, is it okay in that short appointment to just literally go in, see the pulp chamber, and then proceed to the medicaments? Or would you recommend to open it, or does it depend on any factors?
Okay, in short, forget about the root canals. Job is to get in there, relieve the pressure, open the pulp space up, and apply the dressing. That's simple. Like, that's all you have to do on a Friday afternoon.
Even like 3 or 4 millimeters in the middle, that's sufficient?
Pulp tissue, because what then tends to happen is, so the inflamed part is the coronal pulp, or in fact just the top bit of the pulp horn. You'll find once in those cases, you've got to give intrapulpal, and intrapulpal, going back to that, essentially all you're doing is crushing the nerves. It doesn't matter what agent, you could use sterile water, but the pressure crushes the nerve in that inflamed part. And you'll often find the rest of the pulp, okay, it might be hyperemic, it might be bleeding a lot, but they won't feel that. Remove the coronal pulp if you can, if it's not painful, and then just dress it. Don't worry about the root canals at this stage. That's not the priority. In fact, if you then start fishing around the root canals, you're going to start shredding pulp tissue. And unless you get the whole pulp out, that pulp tissue you leave behind in the apical or mid-third, it's going to be inflamed. And then the patient you cause other problems. Mm-hmm. So the pain's coming from the coronal pulp. Deal with that. Dress it, and going back to the restoration, unless there's a gaping hole underneath the MOD amalgam, or it's clearly this it's just the saliva coming in, don't worry about it at this stage. You can temporarily seal all that off with Cavit or Calzinol or whatever you're going to use. Just close the tooth, sedate it, close it, and then get them back in to then strip the tooth apart if you have to. It'll be easy to numb up. You can then do restorability assessment. If it's too knackered from the outset, then you just refer for an extraction or book in for an extraction. But if you're not sure, then don't worry about that. You can assess the restorability and then treatment plan for endo once the patient's out of pain and they're easy to anaesthetise. So don't mess about the pulp root canals at this stage. This is about dressing and getting them out of pain. Don't fish around the root canals. You'll end up.
This is going to be enlightening, Sanj. This is going to be absolutely enlightening, because I know plenty of colleagues who have advised me in the past, and they swear by this, Sanj. They said you won't get the patient out of pain until you file all the way to the apex. Now, is that a myth?
Largely, yes, it's a myth, because
have you heard this?
Vital, so the pain is coming from that top bit. It's not the rest of the pulp. In fact, we'll come on to this. If we get time, things are slightly changing now, the way we treat vital pulps. Okay, this is an interesting conversation where we're now, I think it's too early to bring this in. So we're in the realms of what's called vital pulp therapy, where maybe we don't need to extirpate pulps at all, or the root canal. We can do the coronal pulpotomy as we used to do for kids in immature teeth. Remember the Schweck pulpotomy back in the day? That concept is now coming in adult teeth, not just immature adult teeth, molars, for example, even in mature teeth. And this is the kind of crossover between cariology, the caries management, and restorative dentists coming in. And they've been doing this kind of stepwise technique and all that. But I think endodontists, we've always been not been happy with that, because it's been unpredictable, materials haven't been appropriate, and the risk is the patient could come back in acute pain. They'll come back with advanced disease, endo disease, which then therefore the prognosis lowers, or the pulps completely obliterate. And then when you have to do the endo, it's a nightmare. Things are changing a little bit with the new materials. But at this stage, in terms of emergency management, it's enough just to deal with the coronal part of the pulp. The rest of the pulp often will stay vital. Whether you then do the full root
This
canal
is music to everyone's ears, Sanj. This is music.
So whether you then go and do root canal or whether you go and do the full endo or you don't, and you apply these new vital pulp therapies, that's the next interesting question, because endodontics is changing now. We're doing preventodontics, if you like it.
Very good, very good. I think that'll be a whole new episode. But just to continue on the reign of emergency management, I think what you said is going to be music to the ears of all the GDPs listening who perhaps had this thought that they're going to spend this extra time and extra risk in opening up all the individual canals, filing all the way to the apex. So really what I'm hearing is to get sufficient anesthesia, get in there, open up the pulp chamber just enough to get your sedative in, and we'll talk about sedative in a moment. Now, and don't go sticking your K file. So in fact, your nurse now knows not even to give you a K file for this emergency extirpation, which is brilliant. Would you recommend using hypochlorite? Now, before we can get to that, let's take one step back. I personally, I would always use rubber dam. You know, with your influence on the BES, I can't go to a BES conference and then not use rubber dam for anything like this. So I always use rubber dam, but I've got some colleagues a little more experienced, and they say, Jazz, it's okay because we're killing the nerve anyway. The endobods will sort the bugs out afterwards. So just go in, put some sedative in, and come out. We don't need to irrigate, and we don't need rubber dam. What do you think on that? What is best practice? What do you want from your referring practitioners?
Okay, but I mean, best practice is you've got to isolate the tooth properly, both from a safety point of view and also from a microbiological point of view. Now, that person, dentist, may not be doing the endo, and it's not their problem. They'll go to the endodontist. The problem is, if bugs get in there, saliva gets in there, it'll kill the rest of the pulp. Okay, fine. The plan is to do endo, but the problem is, if an irreversible pulpitis actually is apart from that inflamed bit, it's actually a sterile situation, which is where vital pulp therapy comes in. So you don't want to introduce bugs there because you don't know when that patient's going to get to the endodontist or when they're going to have the endo. It might be weeks, it might be months. And if they get an infection and it gets into the apical, then you're into a different ballgame in terms of prognosis and treatment. So isolation still is important. Now, whether you rubber dam or you compromise, depending on the clinic and if you're working in an emergency department, I know there are other factors. It's easy for me to say in my ivory tower of dental school or endo practice, you have rubber dam there and then. But get good isolation. Your nurse is there, good aspiration, open the pulp up, give it an irrigation. Remember, it's only the coronal part. You're not messing about the root canal, so you just need to bathe the area.
Hypochlorite or Corsadil or whatever. What do you recommend? Hypochlorite. Now, what do you think about people who, because maybe they're not using rubber dam, they're then using chlorhexidine 2% maybe or weaker?
It's better than nothing. They won't be using 2%. They'll be using mouthwash, which is useless. To be honest, it's the surface.
It's true.
They won't be using 2% for sure because that's quite expensive, and most people don't. Even endodontists don't use that. Well, not many do. Even if it's as simple as opening the pulp chamber, you've got isolation suction to stop saliva getting in there. Dipping a cotton wool, pledge it in hypochlorite, and squashing it in there so at least it's bathed. Then dress and close. That's fine. Just be quick. If everything's efficient, you know what you're doing. Hence, keep it simple. You don't need endo files. The aim is all you need is your high speed, ideally rubber dam, but all good isolation. You need your an irrigant even to dip into. Whether you inject into tooth is another issue. Your sedative material and close.
But are you happy for us to use hypochlorite and use maybe a whole syringe of hypochlorite to irrigate the superficial pulp?
It's not a problem. Whether you're going to do vital pulp therapy or do endo, it doesn't matter. For a minute or two, 30 seconds, you're going to do it. It doesn't make a difference. It's not going to do any damage.
But again, we don't need to go into the canal. It's just staying very superficially in the pulp chamber, right?
Yeah, that's all you're trying to do. Get some hemostasis if you can. If you can't get hemostasis, the agent that you're going to use will hopefully it'll kill the pulp off. So when you go back in, it'll be less messy next time. But it's good to have some disinfectant within there. Remember, the dressing material will probably also have a disinfectant effect, so that's fine. But ideally, yes, get good isolation as best you can. And for the sake of a 30 seconds or a minute, it's not the end of the world. You know, you can be careful enough. I think you can be careful enough to use hypochlorite. You don't need much. You don't need a syringe. That's for endo.
Just in a cotton pellet, as you said, is a real gem right there, actually.
Yeah. Just soak it and then close.
I really respect you, Sanj, and I'm not saying I really respect you because what you've given is you really respected the plight of the GDP there, and you haven't been dogmatic. And I really appreciate. It's so easy for you as an endodontist to say, you absolutely must. You're committing a cardinal sin, which we know we are if we don't. But sometimes you only got 5 minutes and you're already 45 minutes into it, whatever, right? So therefore, I really respect that you've given us guidelines in terms of best practice, but you've said that okay, if we have to compromise, let's do it in this fashion, which is going to help us either way. So really good suction, dip your cotton pellet in hypochlorite, and those guidelines you gave. So I really respect you for considering our position sometimes. So thank you for that. Now, the last question in this segment for emergency acute situations before we talk about post-op pain is which is your sedative of choice and which is your temporary restoration of choice?
Sedative of choice, very popular one, and I still like it if you can get hold of it, is Ledamix. This is purely for a coronal pulpotomy. It's not for kicking down root canals. Okay, it's got a steroid in it, so naturally it's an anti-inflammatory. The antibiotic component is broad spectrum. That's neither here nor there, to be honest, but it might have some effect. But it's just the fact it's sedative. You just want to get the patient out of pain. But you need to go back in. You can't leave Ledamix for long because it it does its thing, and it doesn't do much after that. And if there's any pulp beyond that, it'll start getting inflamed. The pulp will become inflamed deeper down. So if you're using Ledimix, it'll keep it quiet for 2 to 4 weeks maybe, but you need to go back in there and do the full extirpation, do the full endo quickly. The alternative, and it's still the gold standard, is calcium hydroxide non-setting. It hasn't got any direct anti-inflammatory properties, but it's a necrotizing agent. It's antibacterial. So kind of indirectly, it'll disinfect the environment. It'll necrotize the pulp because it's pretty caustic. Calcium hydroxide is pretty caustic stuff. It'll fry the pulp it comes in contact with. Very alkaline. And it'll do the job. So when you go back in, you've then got the choice whether you do endo or go down and preserve the rest of the pulp. But calcium hydroxide is fine. Non-setting calcium hydroxide if you can't get hold of Ledimix, because I know Ledimix.
How much do we need here? Because sometimes nurses, depending on which dentist they work with, they've got previous biases. So sometimes they give you a huge splodge of it, and they give you a file because they expect you to take it all the way to the apex, because that's what they're used to with the dentist they work with. Or sometimes they give you like the tiniest bit and a cotton pellet. Now, personally, me, Sanj, I like to use PTFE instead of cotton nowadays. We can hear your thoughts about that. But then, how do you best apply that, and then how much do you put, and how do you seal over that?
Okay, so what I do is once you've got hemostasis or relative hemostasis, if you've got hemostasis, I literally inject the cream. It's like cream. I've got like calcium hydroxide cream into, say, over the pulp chamber floor, a third of the pulp chamber floor, very gently. You can use PTFE. The only problem with PTFE, and I know a lot of endodontists and everyone goes on about PTFE, the problem is if you put that into place, you roll it into a ball. You're meant to roll it into a ball and you squash it in. It displaces the calcium hydroxide. It just squirts back out, so you haven't got the volume. So a better material, and you're right, cotton wool, there's plenty of evidence saying you shouldn't use cotton wool because you often can't see the fibres and they sometimes protrude through and you're going to get an infection. It'll just penetrate through the temporary material on the top. A better alternative I use is sponge pellets. These are the sponge pellets, either Endofrost pellets or Voco pellets. They're better because they're compressible, they're porous, so they'll hold the calcium hydroxide or whatever agent you're in, and it holds a bit bigger volume of dressing material. Unlike the problem with PTFE is you push it in, you're meant to displace it, and it's good because it's antibacterial. And when I say antibacterial, because it's PTFE, bugs don't stick to the material, which is great as an inter-appointment between root canal treatment. It's great for that, or post-operatively before you send back. But for the dressing, you just end up displacing it out, and you want the dressing material to soothe the tooth. So, so sponge pellets.
Fair point.
In terms of material on top, it depends on when the patient's going to come back in. The options are Calcinol, traditional reinforced zinc oxide, or Calcinol. If you think the patient's not going to go see a dentist for a long time, either GI or IRM. IRM is my favourite because it's super reinforced Calcinol. It's rock hard, and in fact, it was designed. Do you know the history of IRM, where it came from?
No, I don't.
It was developed. I'm not sure this is quite accurate, but it was developed by I think it was the U.S. Navy. So they used to during the Vietnam War. So what they used to do is they found a material where they do emergency dressings, get the soldiers out of pain, and they knew they wouldn't come back for months on end, and that's where IRM was developed. They used it there, so it's a long term. It's quite hard. It's not as hard as amalgam or composite, but it's pretty wear resistant. The other property, it's got that eugenol component, so it's slightly antibacterial, which is why a lot of endodontists love it. It's got that long term antibacterial, and it sort of deflects biofilm and bacteria. So IRM's great, but otherwise GI. Capsulated bog standard GI is hard enough, it's resistant enough, and is easily accessible for the final endo. They're the choices.
Cavit, quite soft. Is that okay for a short term?
Short term is fine. It depends on the cavity. If it's an enclosed cavity, literally an occlusal axis cavity, you need depth and bulk of cavit. It's poor wear resistance, but it's okay for no more than 2 to 3 weeks. And it depends on the patient's occlusion as well. So it's okay. It's okay.
Sure. Okay. But we do favour Calcinol, even more IRM, and then use a GIC if appropriate as well. So that's good. If I was to summarise, because the reason I've done a whistle-stop tour of this, because I also want to talk about post-op pain, perhaps after doing RCT. And while I've got this precious time, for those who don't know, we've been months in the waiting to sync our diaries. So I've got this very valuable, precious time to extract everything out of your brain and distribute it to the protrusive artery. So just to summarise so far, guys, we need to get profound anaesthesia. We don't need to explore in that emergency appointment to get to every single canal. We certainly don't need to file into every single canal. If you open up the pulp chamber, place a sedative like Ledomix or a non-setting calcium hydroxide, a foam on top, put some Calcinol or GIC for good measure, IRM maybe if you want something longer lasting, and that should work. Do we have any data on how, because sometimes I've done it maybe some years ago, and it just patients calls up next day and say, I'm still in pain. But most of the time, I'd say 95% plus, patients are out of pain the next day, because I did for a while do an audit the day after, especially when I worked at Guy's in the emergency department. Do we know how successful it is, or has that not been studied?
You mean the emergency dressing protocol?
Yes, the emergency dressing protocol.
Yeah, I'm not aware of any specific studies on that, but anecdotally, from when patients had the dressings done, it seems to within a couple of days, most patients are out of pain once the dentist has been in there. Yeah.
What advice would you give to your patient in terms of, give it a couple of days and analgesics? Let's just finish off with what advice you'd give before we talk about post-op pain.
Yeah, I'd warn them it's not going to suddenly get better. So give it a couple of days. I'd ask them to continue the ibuprofen if they can take ibuprofen or paracetamol. If it's acute pain, then tramadol or something like that. And one thing I also do is just in terms of just symptomatic relief, I'll flatten the occlusion, get all the deflected contacts out, just so there's most of the pain is often on lateral percussion. So just flatten the tooth. The tooth's probably going to be indirectly restored, probably anyway. So just relieve any. The tooth will be hyperocclusion anyway. If there's any apical involvement as well, in multiple-rooted teeth, one pulp could be vital, inflamed, the other part could be dead, so you might also have a combination of apical inflammation. You don't really know that immediately, so just relieve the tooth out of occlusion, all light occlusion, and then post-operative anti-inflammatories, it should settle within a couple of days, should do. And tell them to go to the dentist.
Amazing.
If they're not your current patient, they must follow this up and warn them what could happen, because if again, medical legal hat on, if you haven't warned them this, it kicks off. They'll say you didn't warn them, and just to prevent a complaint, you need to warn them, put it in the notes. This is the advice given. If you're not going to come back to your clinic, this needs to be done. So you just protect yourself for the future.
Yeah, warn them, and also make an entry into the notes that patient warned that this is not the final treatment. Some people just assume that, I've done my root canal and I take a radiograph. There's no root filling material. You've seen, obviously, it's been dressed at some point, probably 5 years ago or whatever. So yeah, good point, well made. So Sanj, let's switch gears a little bit. I recently treated a gentleman. Well, there we have it, guys. You don't need to find and open up every single canal. Just get in there, relieve the pressure, place your medicament, and we also talked about what kind of materials we can use afterwards. So I feel like we covered a fair amount in this group function. Listen, if you are listening on the app, if you're listening or watching on the premium version of the app, just scroll down now, and then you'll see a form, fill in a few details and answer a few questions, and you'll get your half an hour's worth of CPD certificate with all the aims, objectives, and the reflective log, so it's like legit and future-proof. And if you're not already on the app, look, you can download it for free. It's on iOS and Android, and the benefit is you can download these episodes, videos and audios, and any PDFs, and save it to your device in case you have choppy connection. And it's one of those membership programs that actually let you download all the stuff. Like if you're on a membership website for dentistry, then it's very unlikely they'll let you download the videos on your hard drive or on your phone or your tablet. You actually download the video and audio to your device to listen in the future. And if you want CPD and exclusive premium content that I'm making all the time, then I'd really appreciate your support if you support the Team Protrusive and joined the premium package on a monthly subscription, and I'll promise you I'll make it worth your while. Anyway, thanks so much for listening all the way to the end. You're a true Protruserati, and I'll catch you same time, same place on the next episode.